recording again. So you can now see French. Okay, so welcome everyone. It's our last session today with the series of webinars that we have been conducting. I have the great pleasure and honor to be joined by Professor Richard Dillon. Well, in French, that would sound completely different. So, but I hope I didn't make a mistake in saying your name. And Professor Dillon is going to go through APL. So for most of us, it's going to be an introduction since we have not touched upon this topic before. So yeah, really excited to have you here and looking forward to your talk.
Brilliant. Thank you so much for having me. Let me try and share my screen now.
Yeah.
How is it? Is that
I
coming
can
through?
see. Yeah, we can see your screen.
Oh,
Yes.
brilliant. Yeah.
Yeah.
Yeah. So again, thank you very much for inviting me. I'm Richard Dillon and I work in London in Guy's Hospital and King's College. And my talk is going to be about a particular subtype of AML, which is called acute promyelocytic leukemia, or APL. And this is a really interesting disease for a number of reasons. This used to be thought of as the most fatal type of AML, but actually things have evolved very dramatically over the last 20, 30 years, and it's actually now regarded as the most curable type of any type of leukemia. It's also the type that is best understood at the biological and the molecular level, and that has allowed us to develop molecularly targeted treatments and also molecular disease monitoring strategies in order to tailor treatment for individual patients. And that has underlined a lot of the success in improving the prognosis from this disease. And we hope that it's going to possibly serve as a model for improving treatment and outcomes in other types of AML. So what I would do in my talk is I've got 3 real-life cases that I've been involved with managing over the last 10 years or so. And I'd like to use them just to give an overview of the kind of symptoms of APL, and the underlying molecular basis, and then go on to talk about some of the complications of treatment, and then what we can expect in terms of treatment and survival outcomes for patients that are diagnosed in 2021. And please feel free to go ahead and ask me questions if anything's not clear at any point, because it is fairly complicated. So I'm really happy for you to type questions on the chat room, or say the questions, or raise your hand up, and I'll try and answer them. And also we'll have some time for Q&As at the end of the session as well. Okay, so this is the first patient I wanted to start with. This was a patient that we had about 10 years ago now. This is a 34-year-old female who presented with these kind of vague symptoms, so tiredness, feeling breathless, but not dramatically breathlessness, just kind of breathless non-exertion, noticing bruises on her body, and a headache, which is more recent over the last couple of days. And she had a past history of that she'd had breast cancer, and this was 2 years ago, and she had had an operation, lumpectomy, and then she'd had adjuvant treatment with chemotherapy and radiotherapy, and this has all been finished 2 years ago, and the oncologists were completely happy with her. I think the breast cancer, there's no sign of any recurrence, and hopefully that's kind of all kind of sorted now. There was no other medical history. She wasn't taking any tablets. The clinical exam, when we examined her, there was a bruising and a particular rash on her body, but no other abnormalities. And then she went on to have some blood tests, and what this showed was the first thing was she was very anemic, so she had a very low hemoglobin level. She had also had a very low platelet count, which the terminology for this is called thrombocytopenia, and she also had low white blood cell count. So all of the blood cell counts were really low. And when the blood count machine that does the blood count is counting the cells, if it sees anything that looks abnormal, it puts these things called flags on it, and she had the flags put on her blood test for abnormal white cells. And what that would do is, in the hospital, is this flags would trigger us to actually make a slide of the blood and examine the blood cells under microscope urgently. And that's what happened on this case. And I've got a photograph here of the blood slide. And then this cell in the middle with the purple colors. This is a white blood cell, but this is definitely not a normal white blood cell. Apart from being much larger than normal, it also contains these dark purple rod-like structures, numerous of them in bundles, which are called Auer rods. We get these in all different types of AML, but when we see cells with more than one or maximum two of these Auer rods in the cell, this is very, very suspicious for APL. And then if you're a hematologist, you regard this then as an emergency for reasons that will become clear as we're going to go through the talk, but we would regard this as really, we need to take immediate action right away. So what kind of actions would we do if we have a patient with these symptoms and signs? First of all, we will request a genetic test to confirm the diagnosis of APL. And I'm going to come on to talk about this in some detail. And then the second thing we would do is we would urgently start the patient on a treatment. And the treatment we would urgently start them on is actually based on a vitamin A. And the treatment is called all-trans-retinoic acid, also abbreviated to ATRA. And I'm also going to go into some detail about the rationale for this and how why it's important for doctors to be aware about this condition, and why it's important for all doctors in the hospital to be aware that that starting that treatment should be done immediately. There's a suspected APL case. So first of all, just to give you a brief history of the disease and when it was first described, and then how our understanding of the disease has evolved over time. So the first description of APL was actually in 1957, and this was from a Norwegian doctor called Hillestad, and he described a series of 3 cases of which had a very, very similar sort of clinical presentation. And the thing that he really picks out in his description of these cases, the most outstanding clinical feature of these patients, but they had a very rapid downhill course, and they all died very quickly within the first couple of days of being diagnosed. And in all cases, this was due to a severe bleeding tendency. And he described the appearance of the APL cells that you see in the microscope. And as you can see, that one in the top panel in the middle has got these things that we still recognize today as Auer rods and multiple bundles. And then on the bottom part, you can see a characteristic CT scan showing a brain hemorrhage, which should be the most common cause of death for the patients that he described. Now we fast forward into the 1970s and 1980s, and this is when we really started to get a glimpse of the biological mechanisms that are causing this disease, and really these provided a platform that allowed us to begin a rational and effective treatment for this condition. So really this discovery was made by a biologist called Janet Rowley, who is shown in here, who's working in Chicago. And she really devoted the whole of her career to studying chromosome patterns in the cells of patients with different types of blood disorder, most commonly acute leukemias. At the time, her work was really regarded as irrelevant, but looking back now, she really made the underlying discoveries that have permitted targeted treatment across a whole range of blood diseases. For example, she discovered the Philadelphia chromosome, which is the target of imatinib and CML. And relevant to our talk, she analysed the chromosomes in a number of cases of patients with APL. And what she found in these cases, that they all had a really specific chromosome alteration that you never saw in healthy patients. And you never actually saw this chromosome translocation in any other particular type of leukemia or blood disease. So it was really specific to APL. And the abnormality that she discovered was chromosome translocation between chromosomes 15 and chromosome 17. And what chromosome translocation means is that the chromosomes break apart, and then the repair mechanisms in the cell join them back together. But in a translocation, the wrong chromosome gets joined, repaired. So we end up with what we call a derivative chromosome, which is a material from two different chromosomes stitched together by the natural DNA repair mechanisms of cells. Now, in specific cases, this could lead to two genes being joined together, which would never normally be joined together. And indeed, that is exactly what happens in this disease. So we see the translocation between chromosomes 15 and 17 during the 1990s. A number of different independent scientists described the fact that this chromosome translocation actually joins together two genes to make a fusion, what's known as a fusion gene. In this case, the two genes that are joined together, the first one from chromosome 15 is called PML for promyelocytic leukemia, which is a condition that it was first identified in. And the second gene which is involved is known as RAR alpha or RARA, and this is in chromosome 17. And this gene was already known about because it is the receptor for retinoic acid, which is vitamin A. So this fusion is present in over 95% of cases of APL. And very importantly, it was also discovered also in around the 80s and late 80s, early 90s, that giving these patients high doses of retinoic acid, which would bind to the retinoic acid receptor part of the PML-RARA fusion, actually cause the cells to differentiate. So instead of having this very abnormal appearance, they actually transformed over the period of a few days into regaining appearances of normal maturing blood cells. So since those early, really pivotal discoveries, there's been a huge amount of work now to try and understand exactly what's going on. For that reason, APL now is the, well, it was, as I've said, this is the first acute leukemia really to be understood at a molecular level, but it's also the best characterized leukemia in terms of the understanding we have of exactly what's going on at a molecular level. And briefly to summarize kind of two or three decades of research, this is what we think is going on in this disease. So this is in the normal situation. So in a normal person, retinoic acid is taken in the diet, is diffused into the cells, and it binds to retinoic acid receptor. And then the retinoic acid receptor goes into the cell nucleus and it binds onto the DNA. And what it does to the DNA is it activates the DNA and allows the genes to be transcribed and made into proteins. And the particular proteins that are activated by this retinoic acid are genes that are really important for white cells to develop and mature. And examples of those are shown here. What happens with APL? So the first thing that happens in APL is this chromosome translocation happens that I've showed you. And then this fusion gene gets formed, PML-RARA, and that gets then turned into a protein, a fusion protein. And the fusion protein contains half of it is PML, half of it is the retinoic acid receptor. So it can still bind to the DNA, and in fact it binds to the DNA much more strongly than the regular retinoic acid receptor that's present in healthy people does. So it binds extremely tightly and strongly. And when it's there, it also starts to attract other proteins from the cell. And a number of different ones of these have been described, but they all have the effect is that the PML-RARA brings these onto the DNA, and it actually alters the DNA in such a way that it actually shuts off the transcription, translation, and making into protein of the genes that are going to be essential for the blood cell to mature and differentiate. And so that leads to the cell getting stuck in this immature state, which is really what we see in these patients clinically. So this makes perfect sense. So why does giving patients retinoic acid help? So again, many decades of work have focused on this subject. It was first discovered in China, where it forms a part of traditional Chinese medicine, and then subsequently examined by molecular biologists in China and in Europe. So what we think happens is when normal doses, sort of normal levels of retinoic acid, vitamin A in a healthy person would come from a diet. These levels are relatively low. When we give the patient retinoic acid or ATRA, or trans-retinoic acid tablets, what happens is the levels of retinoic acid go much higher than they would in a normal situation. And the retinoic acid can then bind on, well, it binds both onto the normal retinoic acid receptor, but also binds onto the PMO-RARA fusion protein. And it has two effects. So the first effect is it makes it shake off all of the proteins that had recruited onto the DNA that shut off the translation and transcription and turning the DNA into proteins. And the second thing more recently discovered is it actually initiates a process that causes this abnormal PMO-RAR protein to start to break down. And then it disappears off of the DNA and the normal retinoic acid receptor can bind back on, and then the blood cells can start to differentiate and mature again. So this is an example, really the first example actually of a cancer treatment. It's not poisoning the cells, it's not chemotherapy, it's not killing kind of all dividing cells across the board using a toxin. It is actually making the cell differentiate along normal lines and trying to get the cancer cell to behave more like a normal cell. So it's really a complete change in direction in terms of cancer treatment. We hope that this is potentially going to serve as a model for treatment of other types of leukemia, other types of cancer potentially in the future. So let's take a look at what happens when we include this vitamin A ATRA medicine as part of the treatment for APL. So the two lines here are showing the proportion of patients that are still alive after being diagnosed with APL up to a time of 2 years from diagnosis. So you can see that before the ATRA treatment was included, it was 59% of people that are alive after 2 years from diagnosis. And then after the inclusion of ATRA in the treatment, this goes up to almost 80%. So it significantly improves patient outcome. So enough of the basic science, going back to see how this patient is doing. So as you remember, we had a high suspicion of APL disease because we'd looked at the microscope and we'd looked at the blood cell, and it looked very, very suspicious because of the bundles of our rods and the appearance of the cells. So what happened in this case? So the patient was prescribed ATRA, but importantly, that ATRA was not administered in the emergency department. It's highly recommended that emergency departments should keep ATRA as part of their essential medicines, but it's not available in all hospitals in the emergency room. And in this case, it wasn't available. It was requested that the patient should have a PMO-RARA test and that she should transfer to the hematology ward in order to start treatment. However, once she arrived into the hematology ward, the patient was extremely drowsy and low level of consciousness, and she was immediately taken to CT scan. And this is a picture of her CT scan. So this is a CT scan of the brain, and what you can see, which is marked by the red arrow, is there's a huge area of 10 to 15 centimeters in diameter of the lighter white color, which is acute hemorrhage into the brain. And then the second thing you can see is that the normal symmetry of the brain architecture has been disrupted and the midline is shifted across, indicating that there's a dramatic increase in the intracranial pressure. The only possible way to salvage this situation would be to perform an urgent neurosurgery, brain surgery. But however, such operations have a terrible outcome in general. And in most cases, the patient wouldn't survive the surgery. And in this case, based on the new diagnosis of leukemia, which is not treated, and the extremely large size of the hemorrhage, and the fact that the brain pressure was already overwhelmingly high, the neurosurgical team decided that it would not be suitable to operate on this patient, and she passed away actually on the first day of admission into hospital. So that, unfortunately, that is not very, very uncommon in this condition. So we can't really look at the proportion of patients that are going to suffer from these early, what we call early deaths in clinical trial data, because patients like this would never get to enroll in clinical studies because they'd be too unwell and everything happens so quickly. So the number of patients experiencing early deaths in clinical trials is really underestimated. So in order to get good figures about what's the kind of prevalence of this issue, we have to look at whole population level data sets where the cause of death is recorded across the whole population, and the diagnoses are all recorded across the whole population. And how early death is defined in these kind of studies is we're looking for patients that their death is recorded within 30 days of having a diagnosis made of APL. And it's shockingly high. It's really shockingly high. So if we look at this study, first study on the left, the patients with the early deaths within 30 days of diagnosis are shown in a red color. So this is a study from Sweden, which Sweden has actually really excellent health data collection and recording systems. So these figures are very reliable. And actually you can see almost 30% of patients with APL have died within the first 1 month from diagnosis. It's quite shocking. The US, also reasonably good data collection system, possibly not as good as Sweden. Their figure is 17%, and Canada, the figure is 20%. So same ballpark really, somewhere. So we think that rate of early death in this disease is something between 20 and 30%. And what's the cause of these deaths? So the most common cause of death in all of these studies is bleeding. And of bleeding, the most common type of bleeding is a brain hemorrhage, like the one that I showed you. And then we also get bleeding could be anything, anywhere. The second most common one would be bleeding into the lungs, which is called pulmonary hemorrhage, which is also very, very difficult to manage. And then, so that's about 60% of the early deaths. Then about the other causes of early deaths, the second most common one is actually blood clots, which is the opposite of bleeding. This makes it very, very difficult to manage these patients because these blood clots can also be fatal. So these blood clots that I'm talking about, principally, they would be pulmonary embolisms and stroke. And then thirdly, the infections and this thing called differentiation syndrome, which I'm going to come on to mention a bit later in the talk, which is a complication that's really specific to APL. But what I want you to remember is that there's this bleeding problem that's accounting for the vast majority of these early deaths. So I'd just like to take a look at this case about what might have happened if maybe she'd presented earlier or the management had been slightly different. Because the reason that it is such a shame that there's such a high level of early death is because paradoxically, this is the most curable type of leukemia now because of the genetic understanding and the molecular guided treatment. So this is not what happened in this case, but this is what might have happened in this case had things been slightly different, and maybe she'd come in 1 or 2 days earlier, or maybe the way she'd been managed in the emergency room would be slightly different. So in the ideal world, she would have come in, the diagnosis would have been suspected, and she would have been given this ATRA treatment right away. Immediately the diagnosis was suspected in the emergency room without waiting to be transferred to the hematology department. Then the doctors would have recognized that this is a serious problem in APL and they need to be very vigilant, and they need to order the blood coagulation tests urgently and correct these by administering blood products, which could be transfusions of platelets, it could be plasma, it could be what's called cryoprecipitate, which is when you cool down plasma from blood donors and it solidifies out, and this is very rich in a substance called fibrinogen, which is very depleted in APL patients. These could have all been administered in the emergency room before the patient was transferred to the hematology department, and they could have also requested this PMR-RARA test, which is the test for the fusion gene, which is specific for APL. Then the patient could have been transferred to the hematology ward and woken up the next morning to be informed that the diagnosis had been confirmed as APL. She could be treated without chemotherapy, and she had a 95% chance of being cured. So you can see clearly these early deaths are a tragedy, but they're even more of a tragedy because if we can avoid them, then we have such good outcomes. So let's move on now to talk about the second part, which was how could we treat her without chemotherapy and have such a high chance of curing the patient? And this is all to do with arsenic treatment. So you probably will have heard about arsenic, but probably unless you know about APL and either have been treated for APL or know somebody that has, you probably think of it as a poison actually rather than medicine. In fact, yes, that was mainly how it was used throughout history as a poison, but it's also had other medicinal uses at various times. So this is, if you look at the bottom right, this is a medicine where we think this is where the first kind of medical use of arsenic was in this medicine called Fowler's solution. This was used in the 1700s, and this contains 1% arsenic. And this was really popular during Victorian times. Because of the benefit it had, it made your skin complexion appear very fresh and kind of pale and fresh looking, which was particularly fashionable at that time. And if you look at this picture, which is on the top right, this is Ophelia, the painting Ophelia by John Everett Millais. And the model that was but posed for Millais, which is in this picture, is Elizabeth Siddal. She actually died from excessively taking Fowler's solution. Actually, at her inquest, her husband, who was the painter Rossetti, actually said that it was not uncommon for her to be taking up to 100 drops of this Fowler's substance every day to maintain the kind of paleness and clarity of her complexion. And it's thought that led to her early death at the age of 32. It wasn't until the 1970s that actually this started to be tested as a treatment for leukemia. So this, on the bottom right panel, this is a medicine which is developed by Chinese traditional practitioners called Ailing 1, and this contains a number of ingredients, arsenic, mercury, and a number of other ingredients. And this was given by traditional Chinese medicine practitioners to 32 patients with relapsed APL, and this was during the 1970s. And quite shockingly, these are patients who have been treated and now relapsed. Quite shockingly, of these 32 patients, over half of them, actually 65% of these patients went into remission. So this is quite striking, and this really triggered off a wave of research to try and understand, first of all, to verify was this true, to try and understand what could be the mechanism. Was it specific to APL? It appeared clinically, it appeared to be specific to APL, but if so, what was the mechanism that meant it could be used to treat APL, but not didn't work in other types of leukemia? And this research was done collaboratively in China, in Europe, and particularly in Italy. So this slide actually shows data from early studies on mice, and these are mice with a disease very similar to APL. So they've been bred to have the PML RARA fusion and develop APL. And what you can see on the left, there's these mice were not giving any treatment at all. So this is a control group. So all of these mice are dead by 50 days. If we give either arsenic or atra on its own, the mice live a little longer, but actually they all eventually die of leukemia. But however, if we give the combination atra or transretinoic acid and arsenic trioxide, all of these mice are still alive at 9 months. So this suggests that there's a really potent activity. And this led to, again, 2 decades of research really to understand how arsenic, which is a very simple chemical mineral compound, could be having a very specific effect on APL. On this slide, you can see, you're not meant to understand this, just meant to give you an idea that it's mind-bogglingly complicated, really, all of the different pathways that have been identified by which arsenic could be having effects on the leukemia cells. Current understanding is probably the most likely mechanism is that arsenic leads to the PML RARA fusion protein being highlighted by chemical alteration for destruction in the cell's own internal protein degradation system, which is called a proteasome. So it directly leads to the PML RARA protein, which is driving the disease, to be degraded. And this allows the normal retinoic acid receptor to take back its normal place and allow the cells to differentiate. So this early evidence suggested that the combination of arsenic and atra could be able to be an effective treatment for APL. But how did we get to that between that point and using it as a treatment, a chemotherapy-free treatment for APL? And this was because of a clinical study called the APL 0406 study. This study was run by Professor Francesco Lococo, who's shown here from Rome, who very sadly passed away last year. This study enrolled 156 patients with newly diagnosed APL, and it ran between 2007 and 2010. And the patients who enrolled in this study were randomly assigned by computer either to receive standard chemotherapy-based treatment or to receive this new chemotherapy-free treatment with atra and arsenic trioxide. The patients that enrolled into this study had to have what we call low-risk APL. And what that means is, it's done very simply, the white blood cell count when they come in has to be less than 10, and then they're called low-risk APL. So what happened to the patients in this study? So the patients in the chemotherapy-based treatment arm, they had this standard chemotherapy treatment with atra that was being used at the time. And this is known as the AIDA, or the Spanish protocol. And actually, this is the protocol that is still used for chemotherapy for APL to this day. And it's given in cycles. It's given in 4 cycles altogether. So in the first cycle, patients have atra tablets, and they have them twice a day for at least 28 days or until they go into remission. And then they receive 4 doses of a traditional chemotherapy drug, which is called idarubicin, which is an anthracycline chemotherapy drug. If any people in the audience have been treated for AEML, they may well have had this idarubicin drug, and they receive 4 doses of this. And then the second, third, and fourth cycles are variations of the same. So in the cycle 2, the patients received atra twice a day for 2 weeks and another 4 doses of idarubicin. In cycle 3, they had atra for 2 weeks and a different chemo drug called mitoxantrone. And in cycle 4, they had atra for 2 weeks and idarubicin for 1 dose. And each of these cycles takes about 1 month to give. So it's, as you can see, it's 4 doses of chemotherapy and then about 3 to 4 weeks recovery time to allow the white cell count to recover for the next treatment to be given. So that meant that the treatment took about 4 to 6 months in total. What are the main side effects of the chemotherapy treatment? So this is in common with all chemotherapy for acute leukemias. The main side effect is that the chemotherapy also kills the healthy white blood cells. So what's drawn on this graph is what the white blood cell count and what happens to it during one of these chemo cycles. So at the beginning of the chemo cycle, the chemotherapy is given, in this case, 4 doses, and the white cell count starts off, it can either be high, normal or low, and it drops down to absolute 0, and it stays on absolute 0 for approximately 4 weeks until which time the white cells start to grow back. And during that period, really the patient has no immune system and they're prone to all kinds of infections, and they can be very serious. So they're prone to bacterial infections. They're prone to also infections that would not affect healthy people, such as virus and fungus infections. So that is the main side effect of chemotherapy treatments across AML, and this is also the main side effect of chemo treatment in APL. And other side effects of the chemo treatment are, as is well known, hair loss, nausea, mouth ulcers, gastrointestinal upset, all of these acute side effects that are associated with a chemotherapy and vary from person to person and can be really nasty. And then we have the long-term side effects of chemotherapy. The main ones are loss of fertility or reduction in fertility for both men and women. And then the relatively rare but very bad or most feared side effect is secondary cancers caused by the chemotherapy itself. And possibly the most feared secondary cancer caused by exposure to chemotherapy is actually, paradoxically, AML, a therapy-related AML. So a second AML that occurs as a result of the treatment for the first AML. It sounds very, very improbable, but it happens. We see this, and it's very, very, very difficult to treat. So really a lot of unpleasant side effects with these treatments, but it's just an effective treatment. And then what about patients that had the chemotherapy-free treatment? In this case, the patients had to have 5 cycles instead of 4, and the cycles lasted longer. So in the first cycle, the patients had to have Atra tablets twice a day for at least 28 days, but up to 60 days until they went into remission. And they had to have arsenic injections every day for the first week. And then they had to have arsenic injections twice a day for a further 7 weeks, for a further 8 weeks of the cycle. So in this case, the cycles are 8 weeks long instead of 4 weeks long, and there's 5 of them instead of 4. Meaning that in total, patients are on treatment for 9 to 10 months, so the treatment's a lot longer. But however, there should be much less short and long-term side effects. So what are the side effects of arsenic specifically? So these are for the main ones. The first one is you can get ECG changes. So the ECG is the heart recording, which hopefully some of you will be familiar with, where the electrodes are placed on the chest, recording the electrical current in the heart. And it causes a very specific, arsenic causes a very specific abnormality, which is the lengthening between 2 of the waves. And if that's not monitored carefully, that can then lead to heart rhythm disturbances. Secondly, the liver function blood test can become abnormal. In fact, this happens really commonly. This happens in well over half of patients. It's quite unusual for patients to experience symptoms as a result of that, but the blood tests quite often become very abnormal. Third side effect, not specific to arsenic actually, but specific to APL treatment, is called differentiation syndrome. We're going to come on to talk about that in a minute. Fourth side effect, the white blood cell count can start to go up. And it can actually go up very high. So the treatment hasn't got any chemotherapy in it. It's making the cells differentiate. So the white cell count can go up because there's no chemotherapy in it. There's no kind of break on that, killing the cells at the same time. So we can end up with a very high white blood cell count. And in fact, very occasionally, the patients end up having to have a single dose of chemotherapy to control the white blood cell count. Important, in this arsenic-atra chemotherapy-free treatment for APL, it's really rare to get neutropenia, so it's really rare to get serious infections like we can get with the chemo treatment. So what were the results of the APL 046 study? Well, the results are shown here. And this is the number of patients who were still alive 4 years after they had entered the study. Patients with the chemotherapy-free atra-arsenic treatment, 99% of them were alive. And with atra chemotherapy, 91% of them were still alive. Both very high numbers, but the chemo-free treatment, actually, the difference was statistically significant. So it's a better treatment. When more patients are alive, the side effects are less. It's a longer process to go through, but the outcomes appear to be better. Important, the Lococo study didn't include patients, as I mentioned, it only included patients with what we call low-risk APL, and that means patients with white blood cell count of less than 10. Didn't include patients with high-risk APL, which is white cell count more than 10. So for that reason, at the moment, it's not approved to give chemotherapy-free treatment to patients with high-risk APL, which is about 1/3 of patients. So what happens at the moment is patients with a white cell count of less than 10 receive treatment with atra and arsenic trioxide in almost all countries worldwide now as a first-line treatment. Patients with 1/3 of patients with a high-risk APL with a high white blood cell count, most countries, these patients will receive still chemotherapy-based treatment. However, at the moment, there is a study ongoing throughout a large number of European countries looking at the use of atra and arsenic in high-risk APL. And this is called the Apollo study. And so far, 79 patients have enrolled into the Apollo study. And I believe their target is to enroll approximately the same number as the APL 046 study, so around 150 patients. So hopefully in a couple of years, then we'll have the results of that. And if we expect it to be better, but if that's confirmed, then hopefully we'll be able to use arsenic trioxide in chemo-free treatment really for all patients across the board. Important, in this Apollo study, because the white cell count is high to start with, and as I mentioned, the arsenic atra combination can make the white cell count go up. Actually, all patients get a single 1 dose of chemotherapy in the first cycle to control the white cell count. But of importance, they don't get any more chemotherapy in the rest of their treatment. So it's not quite chemo-free, but it almost is. So I'd just like to come on to talk about 2 other cases to bring out, it's 2 real cases that have been treated, that I've been involved in their treatment, and to bring out some important complications and important facts about APL. So this is the second case here. So this patient is slightly older. She's 51 years old. And again, she has presented to hospital, again, with these fairly vague symptoms, which is really common. So fatigue, breathlessness, and people have commented that she looks pale, and not because she's been taking Fowler's solution. No, a patient has no medical history. She had a normal exam, and she went on to have blood tests. And yes, you probably will know this is quite often the stumbling block for patients with acute leukemias, is that they find it difficult to get the blood test because the symptoms are quite vague. Doctors can tend to write them off and say that you might be tired, you might need a holiday, you might have a virus, all sorts of things. But once the people have the blood test done, it seems to be the diagnosis gets made very quickly. So this patient, she's very anemic, hemoglobin is 62. White blood cell count is very high, 66, it shouldn't be more than 12. And a platelet count is 45, very low, should be at least 150. And again, this is going to flag urgently, really, for people to look at the blood film right away on a microscope. And then this is the blood film from this patient. You can see it's really different from the other one I showed you, or hopefully if you can remember it. So the other one I showed you, they had the cells had all of these dark granules, and they also had lots and lots of these bundles of hour rods. And you can see this is really different looking. They don't seem to have the granules and not many of them have the hour rods. But having said that, this cell here definitely has the hour rods, bundles of them, possibly probably got 8 or 10 in there. And then they've got this really characteristic appearance where the nucleus of the cell, which is the violet color, looks like it's been twisted over on itself. And this is really typical appearance for what we actually call variant APL. So this is not the classical appearance of the APL, it's a well-known variant that we see in probably about 20% of the cases. And typically this variant appearances, we see it in those patients that have a high white blood cell count, quite often have this variant type of APL. Variant APL still has exactly the same genetics. It still has the PML-RARA fusion gene. We're not sure why the morphology is different in the variant cases. It's unclear still, despite intensive research. Anyway, so this is the ongoing story from patient case 2. So in this case, the white blood cell count in the blood is so high, actually we possibly don't even need to do a bone marrow test on this patient because there's so many abnormal cells in the blood. We can take the blood sample straight down to the genetics lab and ask for urgent, what we call a FISH test. What the FISH test means is it is called fluorescence in situ hybridization. And what essentially this means is the genetic laboratory technicians will have fluorescent labeled probes to bind onto the PML and to bind onto the RARA genes on chromosome 15 and 17 respectively. And the probes have different fluorescent color labels on them. And if a patient has this PML-RARA fusion, these two probes are going to be drawn together and sit on top of each other and create a third color. And by looking at that third color, which is a mixture of the two colors on the different labels, the genetics laboratory technician will know that there's a PML-RARA fusion, and they should be able to do that within a few hours. And this was positive. And then the patient was then, as I said, these patients currently, they're not suitable for treatment with chemo-free treatment at the moment. This patient could enroll into the Apollo study if she's in one of the countries where it's running. Unfortunately, the Apollo study is not running in the UK. So she started on this AIDA Spanish chemotherapy-based protocol, including ATRA or transretinic acid. Okay, so I just want to tell you about a few things that happened during her treatment, because they kind of summarize quite well a lot of the complications that we can get when treating a patient with APL. So this is on the 3rd day of her treatment. She started to feel very breathless suddenly, started feeling very breathless, even though she wasn't doing anything sitting on the chair, and she got chest pain. And her oxygen saturation was 89%, and what it should be is it should be 96% or above. And of course, these days, when we think about coronavirus, so she had the lateral flow test, and this was negative, and then she was rushed down for a CT scan. And this is a CT scan. And what it is this, what we've marked with the red arrow, which is like the grey shadow, which is spreading across both sides. This is a pulmonary embolism. So the white structure that the clot is sitting in, this is the pulmonary arteries that bring blood into the lungs. And then the grey colour is within the pulmonary arteries, and it's a massive clot, and it's spreading across both sides. And these kind of pulmonary embolisms, they're very, very fatal. Why I mentioned this, I said at the beginning that we quite often get blood clots as well as bleeding and APL. Typically, when we get the blood clots, it's not right at the beginning, it's once the patient starts on treatment. So this could happen like in the 1st or the 2nd week of treatment. This could happen. Unusual for this to happen right from day 1, like when I showed you the brain hemorrhage. The blood clots seem to happen once the patient started treatment. And very high rate of mortality in this situation, even for very young patients. They can suddenly drop dead on the ward with this kind of issue. Fortunately, In this case, it was picked up quickly. The patient was able to receive treatment with aggressive anticoagulation and recovered. Unlucky lady, however, by day 18, she started getting high temperatures and a cough. And again, she was short of breath. And again, she had low oxygen saturation. And this time it was 91%. And like the day before, having had successful treatment for her pulmonary embolism, it had been 98%, so dropped right down. And again, these symptoms these days, everyone would think it's coronavirus, but the lateral flows again negative. So she's taken back down for a scan. And this is the scan pictures, excuse me. So there's three things I've labeled here on an arrow. The top one is around the heart. There's a fluid accumulation around the heart, and this is called pericardial effusion. Second arrow, in the lungs, you can see there's these white infiltrates in the lungs, quite widespread throughout the lungs. This is called pulmonary infiltrates, and you can see it's on both sides of the lungs. And thirdly, behind the lung, there is quite a thick rim of fluid sitting behind the lung, which is called pleural effusion. And then this is highly suspicious now for what I was mentioning earlier, which is this thing called differentiation syndrome. This differentiation syndrome doesn't happen in other types of AML. It only happens in APL. And the reason it only happens in APL, because at the moment it's only AML where we're using treatment that makes the cells differentiate rather than just killing them off. So as the cells differentiate, they can get lodged and stuck in different parts of the circulation. And this is relatively common. When does it happen? So it comes in two peaks. The first peak is in the first week when the patient's just started treatment. Those ones that happen in the first week, they tend to be more severe. And then there's the second week, not usually, and then the third week of treatment. And those ones, they tend to be less severe, but they can still be severe. And what we're looking out for, there's no specific test to diagnose someone with differentiation syndrome. You can't do a blood test and say that's that. It has to be based on a combination of these clinical features. So the clinical features are shown on the right-hand panel. These are fevers, high temperature, dyspnea, which means breathlessness, pleural and pericardial effusions, which I showed you, which is fluid around the heart, fluid around the lungs. And then these pulmonary infiltrates, which are actually in the lung tissue itself. You can see either on the X-ray or on the CT scan, you see the infiltration. Other symptoms and signs, patient could have weight gain, they could have hypotension, which means low blood pressure, and they could have acute renal failure. And depending on how many of these symptoms and signs that they've got, if they've just got one of them, of course, if somebody just has a fever, this does not necessarily mean they've got differentiation syndrome. They could have an infection. So if they've just got one symptom or signs, they call it possible differentiation syndrome. So we're keeping an open mind. However, once you have 2 to 3 of these, it's much more likely that you have differentiation syndrome. So we start to call this moderate differentiation syndrome. This is really common, happens in 12% of patients. What would we do on these patients? We would start them on steroids. So we give them dexamethasone. We would monitor them carefully, but we would carry on with their treatment. Then what happens if the patient has 4 or more of these features? This is severe, now called severe differentiation syndrome. So another 12% of patients. It's important to point out this is really dangerous. There's 26% chance of fatality if you get diagnosed with severe differentiation syndrome. So what would we do is we would start the patient immediately on the steroids, the dexamethasone, if they weren't already on it. Why would they already be on it? Because some centers give a preventative dose, and then also the patient might have also developed into a severe from a moderate. So they might already be on it. But this important thing is we would stop the treatment. So stop the ATRA, stop the arsenic, and we would stop it for at least 3 days or until complete resolution of all of the symptoms, whichever took the longer. We don't need to worry about that because if the differentiation syndrome started to happen, the treatment's already starting to have its effect. We don't need to worry about holding the treatment. This patient had 5 of these symptoms. So she had severe differentiation syndrome. We stopped her treatment. we stopped the ATRA. We've already given the chemotherapy. So the chemotherapy, as I said, is the first 4 doses. The ATRA is then given over 28 days. We stopped the ATRA and we gave her dexamethasone. She went into intensive care and she needed non-invasive ventilation, which is CPAP, but she didn't need intubation and she recovered. And the reason I say this is the unluckiest lady, because she then got another side effect of treatment, which is on day 26. She's back on the ward, she's back on the ATRA, she's back on the 4 days, and she said she has a headache and the vision is blurry. And she had a scan, she was taken for a scan of the head, normal. And we then got the eye specialist to come and look in her eyes, and that they mentioned that they saw this thing called papilloedema. So what normally you can see in the back of the eye is you can see the optic disc is a nice round circle. In this case of papilloedema, it's very, very blurred, the disc margin, and we see these red marks, which is hemorrhage. This indicates that the pressure in the brain is raised. This is a side effect of ATRA, and in this case, we did a lumbar puncture on the patient, which showed that the intracranial pressure, the pressure in the brain, was very high. We're able to stop the ATRA, and then over time, the vision completely resolved back to normal. And with the next cycle of treatment, she started on a half a dose, and the blurry vision didn't recur, and the eye doctors again examined her eyes, and things had all gone back to normal. So that is pretty much all of the side effects that you might be able to get with APL treatment. And then just a final case I'd like to talk about because it really highlights another development, which is one thing that our group's been very involved with, which is the development of molecular monitoring techniques called minimal residual disease, or MRD monitoring techniques for AML. And this was all pioneered in APL first. And I'm just going to give you an example of how this is used and how it's done and why it's useful. And then this is obviously now been transferred to lots of other types of AML, and it's becoming much used much more across the board. But to start with, this was only an APL. So this patient is 17 years old, and he was diagnosed with high-risk APL 18 months before, when we're talking about, and because he had high risk with a high white cell count, he was treated on the chemotherapy plus ATRA, the AIDA protocol. Actually, his white cell count when he was diagnosed was 86, and it's very high. So we even call him extra high risk because of this very high white count. And because he's got high risk disease, he underwent sequential molecular monitoring. So we recommend sequential molecular monitoring for high-risk patients. For low-risk patients that receive arsenic ATRA, as I showed you, these patients have a greater than 95% cure rate with ATRA arsenic. They're extremely unlikely to relapse. So these days, actually, they don't even need to receive sequential molecular monitoring, but this patient definitely does, because for patients treated with chemotherapy protocols, the relapse risk is approximately 20 to 30%, up to 1/3. How is this useful? Well, again, this goes back to the genetic abnormality that underlies the disease, which is this fusion gene, PML-RARA fusion. Now, clearly, this fusion gene provides a DNA sequence that you're never going to find in a normal, healthy person. And it's not going to be in any of the cells that aren't leukemia cells. So it's very, very specific to the leukemia cells. And it allows us to design PCR assays. So these are the same assays that are done to detect coronavirus, but they very specifically detect this genetic sequence, which is only found in the APL cells, and they are very, very sensitive, and they can detect down to about 1 cell in 100,000 healthy cells. Now, David Grimwade and colleagues were able to identify at the genomic level exactly which parts of the DNA are involved in the PML-RARA fusion. Unfortunately, there's only a relatively small number of combinations. So that means in any given patient, we can identify the exact what we call the break point of the fusion between the two genes, and develop a PCR-based molecular assay to specifically amplify that patient's own particular fusion breakpoint. And this is really important because it gives us a very high level of sensitivity. Why is that important? So traditional methods of assessing whether the patient has responded to treatment would be that you would take a bone marrow from them and you would smear it on a glass slide and you would look at it on the microscope. And you count the cells manually. And if you see less than 5% of immature cells, the patient's called in remission. But however, if we have, that only gives us a level of sensitivity down to 5%. That means that we could actually, if you calculate it, you could actually have 10 to the power of 10 leukemia cells still in your body and still be called in remission. Also, you could have none, and there's no way of telling. So if you did have 10 to the power of 10 leukemia cells in your body, you would expect you'd have a really high chance to relapse very soon. But on the other hand, if you didn't have any, you would expect that you'd have a very low chance to relapse, and in fact, maybe it would be cured from the disease. So it'd be really nice to be able to know which one of those situations you'd be in. So techniques to try and evaluate this, the first technique is called flow cytometry. And in flow cytometry, what happens is we use fluorescently labeled antibodies against proteins on the cell surface, and we're looking for combinations of proteins that we never see in normal healthy bone marrow cells. And this allows us to detect levels of disease down to about 0.1%. So this is clearly much better. But however, even if this flow test is negative, we could still have 10 to the power of 8 leukemia cells in our body, or we could have none. However, if we're using molecular techniques, we're now able to bring the level of sensitivity right down so we can detect one cell in 100,000, so 0.01%. And this allows us much more precision to identify those patients that are at a high risk of relapse, so in the light and medium color blue boxes. However, these tests are still not perfectly sensitive, and we may still actually have a patient that could have up to 1 million leukemia cells in their body, and we're not able to detect it using these molecular methods. The sensitivity is very good, but the sensitivity is not infinite. So it is still possible that a patient who's MRD negative could actually still relapse, although you'd expect that'd be much less likely, and you'd expect it to happen much later on. And you'd expect actually by sequentially monitoring the patient, you would be able to detect the rising MRD levels and be able to go in and preemptively intervene. And that's exactly the strategy that we do for APL. So we would preemptively intervene to give treatment to prevent relapse, first of all, in those patients that they don't clear their MRD. So they finish treatment and they still have detectable minimal residual disease. However, for those patients, they do clear their MRD, particularly for those patients who have been treated with chemotherapy, we know that there's still a chance of relapse of 20 to 30%. So what we do in those cases is that we track their bone marrow sequentially every 2 to 3 months. And for those patients that are going to relapse, about 2 to 3 months before they relapse, we will be able to detect a rising MRD on the molecular MRD assays. And that's shown by the pink line. And rather than waiting for the patient to experience a full-blown hematological relapse, we would go ahead and treat them with arsenic and nitrous salvage chemotherapy treatment and put them back into remission. And why would we do this? The reason why we would want to do this is because if you allow the patient to fully relapse, they're then exposed to that risk of early death again through bleeding. And that risk, as I mentioned, is likely about 20 to 30%. So really, this is a technique that's applied to prevent the patient ever getting into that situation. And how effective is this at preventing relapse? So this data compares to clinical trials. The first one on the black line is in the UK AML 12 study, in which we did not use molecular surveillance. And 12% of patients relapsed overall. And on the red line was the subsequent study, AML 15, in which all the patients were recommended to receive molecular monitoring, and 5% of the patients relapse. So it more than halves the risk of relapse. And is it cost effective in terms of the costs and benefits? Well, it appears that the cost of this monitoring is £1,000 per quality adjusted life year saved. So to give you an idea, funding bodies in the UK will typically approve a drug costing up to £30,000 to £60,000 per quality adjusted life year saved. So highly cost effective. What about this patient? Going back to our patient, so he underwent surveillance molecular MRD monitoring. You can see the data points shown here. And about 2 years from diagnosis, you can see that the MRD levels have gone up and are positive. Now, we would never do anything based on a single result because of the fact that these tests could be prone to lab errors or false positive or sample switch or all kinds of issues. So we would always make sure to repeat that. So this was repeated, so positive again. So this is now called a molecular relapse. And what we know from studying hundreds of patients is that if nothing else is done, this patient will relapse. And the time to relapse is likely going to be 2 to 3 months from now. Important, in patients with molecular relapse, they quite often have relapse at other sites as well at the same time. So not necessarily in the bone marrow, but possibly the commonest site, but with the relapse might be in the spinal fluid. So always we would do this procedure. You possibly know about this procedure, which is called lumbar puncture. So in the lumbar puncture procedure, a very fine needle is inserted into the fluid sac that lines the spinal cord. And this was done in this patient. And it shouldn't normally have cells in it. It should just be clear, what they call gin clear. And in this patient, it's not gin clear. It's got lots of cells in it. And actually did this FISH test on these cells. It's got the PMRR. So it's definitely what we would call a central nervous system plus molecular relapse. And it's quite a common combination. And actually the patient didn't have any symptoms of a headache or any other symptoms that would lead you to suspect, hence the importance of why we would do this lumbar puncture. And so the treatment for this, so first of all, the patient had what is called intrathecal chemotherapy. So what that means is we do the lumbar puncture, and at the same time, some chemotherapy is injected into the spinal fluid, and you have to have that done twice a week. And at the same time, we gave the patient, remember he was treated with chemotherapy, so he hasn't had any exposure to arsenic. So we treated him with arsenic plus atra treatment. And this is the result. Sorry, he had 5 cycles of that, so the full schedule. And then he had what is called an autograft. So it's a bone marrow transplant, but rather than from a donor, it's from yourself. So stem cells are harvested from your own bone marrow. You then undergo chemotherapy and radiotherapy, and then the stem cells are infused back. And the results, you can see that the bone marrow went back negative after this treatment. It's remained negative actually now 2 years from the relapse. This patient is very likely to be cured from the disease. It's unlike other types of AML, relapses are very treatable in APL. It's extremely unusual for a patient to die of their disease with APL these days. What they might die from, first of all, they might die from the early deaths, which we mentioned. Secondly, they might die from the side effects of their treatment, particularly if they had chemotherapy or if they had to have a bone marrow transplant. But for a patient to die of relapse, I mean, we monitor all of the patients from the UK. I haven't seen one for more than 2 years. Sorry, I'm aware I've gone slightly over my time, but just to summarize the talk, to recap, we first of all talked about typical signs and symptoms of APL, very non-specific and vague, importance of getting a blood test. We talked about how important it is to recognize this APL because of this early death due to bleeding, and therefore the fact that it's urgent to diagnose these patients and to start treatment on them. They should be done on the same day, right away. We talked about what is the molecular mechanism of APL, that it was the first molecular mechanism to be described in acute leukemias, which is this fusion called the PML-RARA chromosome fusion, and how that's led to the development of molecularly targeted therapy, and which is all-trans-retinoic acid and arsenic trioxide, and how we can use these in combination to give chemotherapy-free treatments. The first time we've ever been able to do that in acute leukemia, still the only one, hopefully not the last one. We talked about some complications of treatment. We talked about differentiation syndrome, which is a serious complication that only happens in APL, which is manageable with steroids. We talked about pulmonary embolisms and other blood clots. And we talked about this intracranial hypertension presenting with blurry vision. And we talked about the development and the use of molecular monitoring to prevent relapse. Thanks so much for your attention, and I'm looking forward to your questions.
Thank you very much, Professor Dillon. Was great. For me, well, I don't have a particular question, and I haven't seen any questions in the chat, but it's more of a comment. I mean, we know the symptoms are very vague, but then from what you said and from the cases that you presented, it's clear that it's an urgency. So how come that, I mean, how this can be improved? Because it seems that it's even a question of days, right? Especially when you presented patient case number 2, it's like from one day to the other, she went completely in a bad state, right?
We actually, in the UK, we have a campaign run by Blood Cancer UK so it's a two-prong attack. So awareness for the population. These are the symptoms that could be leukemia: big bruises on your arm, headache, a rash, feeling generally unwell, but also to educate the general doctors about what to look out for. Normally when they do a blood test, it's really obvious what it is, but it's getting them to do the blood test and think of that. So I think it's awareness campaign really is the key to that.
But is it, I mean, is it literally from one day to another?
This case I showed you, yes. And this is not very uncommon. We hear about such cases happening, I hear about them every couple of weeks. It happens. And it can be literally within a few hours.
Wow. Oh, okay. This is quite scary, I guess.
It is, but it's rare, so APL, how many cases we would get in a year? In the UK, I guess we would get 100. So it's a rare disease.
Yeah. Okay.
But the awareness about the symptoms, awareness among the doctors about what to do, and having everything, really streamlined is really life-saving.
Yeah, because that's the point. I mean, if it's such a rare disease, then how can you make sure that you have trained physicians who might potentially see one case in their whole career, right?
Exactly. But however, remember the symptoms of this APL disease, it's really similar to other types of AML, which we know, like I see patients that have been to the doctor 5 times and not had a blood test, or they've been to the emergency room 4 or 5 times and not had a blood test. So actually awareness of symptoms of APL will also generate awareness of AML in general, acute leukemias in general, making people think of this. That is vague, that a blood test will easily diagnose it, a very simple blood test, just a blood count. So I think, we're not just trying to make people aware about APL, we're trying to make people aware about acute leukemias really, and hematological malignancies in general, and thinking of that, okay, they're rare, but they're very curable if they're diagnosed early.
Yeah. Yeah, so I think that fits quite nicely with what Alan is doing, because we have World Leukemia Day coming on the 4th of September. And so we are running an awareness campaign on the general symptoms of leukemia. So the let's say, the main symptoms like fatigue and shortness of breath, or bruises and pain. So we are also trying to raise awareness in the general amongst the general public about leukemia. So
It's fantastic to hear.
yeah, so I think that fits quite nicely with what you just said, which is a nice ending of the seminar. So what I would do as usual is to post the recording of the presentation, and also if you are okay to share your slides, so I can also put the link
Of course, I'll
on
email them to you right now.
Cool. Okay, on the website, and so it's going to be posted on our website and also on Facebook. So you can always come back to the recording and the slides. And if you think of any questions that you may have in between after the digestion of all this information, you can email me and I will pass on to that Professor Dillon. And yeah, with that, I would like to really thank you for your time. I can imagine you are very, very busy at the moment. So really a big thank you from all of us for being with us and making APL quite understandable for us, which I guess is quite of a challenge for you. Yeah, and yeah, with that, I wish you all a very good evening. For people who are interested, we are having a second talk in 10-15 minutes on CAR-T cell therapy. So you can stay online or you can redial in 15 minutes for the next talk. See you soon.
Thanks so much for having me. It was a
Thank you,
pleasure.
Professor Dion. It was really good.
Pleasure.
Thanks a
Thank
lot.
you.
Thank
Bye-bye.
you.
Cheers.
Bye. Bye-bye.